Hi everyone, thanks for listening. Today I'll be talking about hypercalcemia, but this time around it will be about treatment. If you haven't listened to the causes, symptoms, and diagnosis, that is parts 1, 2, and 3 respectively, please kindly do. And with that, let's go. Okay, treatment depends on the etiology or the cause or causes. For example, if it's as a result of hypoalbuminemia, you just give albumin. If it's a result of milk alkaline syndrome, you don't need to do parathyroid hormone and do all this stuff. Also, it depends on the level of calcium or severity, because it's not everybody that are going to jab with so many strong medications that I'll be talking about. If the value is very low, you might do nothing but advise against diet and so on. And also depends on complications and, of course, comorbidities. Why do we have to treat? The aim is to decrease serum calcium level by inhibiting bone resorption, increasing urinary excretion of calcium, and decreasing intestinal absorption. Remember, we cannot treat without the value of albumin as well. So, the value of albumin is very, very important. You can check my channel for the diagnosis of calcium already published. So, let's go with corrected calcium level because that is what we are going to be dealing with, and that's very important. Okay, we have our corrected calcium level result taking into account the serum calcium level and the albumin, and the level is mild. That may be symptomatic, or if there are symptoms, the symptoms will be mild. And at this stage, the corrected calcium level will be less than 12 milligram per dl or 3 millimoles per liter. Or the ionized calcium level will be less than 8 milligram per dl or 2 millimoles per liter. Please, no treatment at this level. No treatment. But we're not going to just close our mouth and tell the affected person or persons to just go. We will address some issues. The affected individual should avoid thiazides, no lithium, and if the person must take lithium for hormone purposes, for psychiatric disorder, we have to discuss with the attending psychiatrist. No dehydration here, so well hydrated. Immobilization is not welcome, so must be active. If this individual is on bed for a long time, then we need to address that. High dietary calcium intake should stop and must increase food intake to about 6 to 8 glasses per day. B. Moderate hypercalcemia. At this level, it will also be asymptomatic or just mildly symptomatic, and we'll be looking at corrected calcium level between 3 to 3.5 millimoles per liter. We have to follow the steps as if we are treating mild hypercalcemia, and that will include stopping thiazides, lithium after discussing with the attending psychiatrist, increase mobilization, increase fluid intake per oral at least 6 to 8 glasses per day, but to anyone vomiting and cannot take per oral, you are free to give your IV fluid. And of course, decrease the diet rich in calcium. And note this, if the rise in the calcium level is rapid, then we have to treat like stage C, which is severe hypercalcemia. Don't be curious, we're going there next. Now, C, that is severe hypercalcemia. Corrected calcium level greater than 3.5 millimole per liter is qualified enough to be tagged severe hypercalcemia, or ionized calcium is greater than 2.5 millimoles per liter. At this level, we'll start aggressive therapy. The other situation that may lead us to aggressive therapy is acute rise in calcium and possibility of altered sensorium. We're going to treat all those two cases like severe hypercalcemia. Then, that will involve IV fluid, normal saline, 200 to 300 ml per hour, and we'll be checking the urine output to make sure we are within 100 to 150 ml per hour. Also, we can use loop diuretics. We use loop diuretics if there is heart failure or renal failure. But we don't need loop diuretics if there is no heart failure and there is no renal failure. We can use calcitonin. Calcitonin at 4 international units per kilogram every 6 to 12 hours. You can check my channel for the publication on calcitonin already published. And we have to measure the calcium level again. Be careful with hypersensitivity or tachyphylaxis when it comes to calcitonin. And we have to measure that or look out for that all between 24 to 48 hours. So, because we don't want tachyphylaxis or any trouble with calcitonin, we can limit the treatment to only 24 to 48 hours. However, we can increase calcitonin to 8 international units per kilogram. For more information on calcitonin, you can check my channel for that. You can use zoledronic acid. Zoledronic acid 4 mg intravenously, but very slowly over 15 minutes. Or you may go for Pamidronate at 60 to 90 mg over 2 hours. But zoledronic acid is better if the cause is due to malignancy. If you are dealing with a severe renal impairment, please no bisphosphonates here. You can, however, use Denosumab with calcitonin. We are going to advise against the use of calcium-containing foods or thiazide to prevent further increase in calcium. Renal replacement therapy will be adopted using hemodialysis or peritoneal dialysis if corrected calcium level is 4.5 to 5 millimoles per liter. Then, renal replacement therapy straight away, particularly if you are dealing with renal failure. What about someone on hemodialysis? What are you going to do with phosphorus? If there is no renal failure, you have to prevent hypophosphatemia because that is what is expected in phase of hypercalcemia, right? Then prevent hypophosphatemia by adding phosphorus 4 mg per dl to the dialysis solution. How about the use of glucocorticoids? Glucocorticoids like prednisone 20 to 40 mg per day will reduce serum calcium by decreasing calcitriol due to granulomatous diseases. How about denosumab? If biphosphonates are failing, please grab your denosumab at 120 milligrams subcutaneously every week for 4 weeks. You later then give the same dose every month. Note: denosumab is not cleared by kidney, hence it is fine in the face of renal failure. That is the time you cannot use bisphosphonates. But if you are using denosumab in renal failure, expect osteonecrosis of the jaw. That is very possible. Calcimimetics. Calcimimetics, for example, cinacalcet, is used in hemodialysis or parathyroid carcinoma with elevated calcium and phosphorus, and also used in secondary hyperparathyroidism. Follow-up and prevention. We have to treat all the underlying causes, prevent skeletal complications from metastatic bone lesions by giving Zolendronic or Pamidronate every 3 to 4 weeks. We can give denosumab 60 mg subcutaneously if Zoledronic is contraindicated. And we have to advise affected individuals to stop calcium-rich diets, or at least decrease to the barest minimum. Still on follow-up and prevention, no more calcium-rich medications if possible. For example, we have to talk to the attending psychiatrist when it comes to lithium carbonate for mood disorders, or the gastrointestinal tract experts when it comes to milk of magnesia. Antacids rich in calcium should be stopped, and we have to advise affected individuals to increase exertion because immobilization is disadvantageous. No excess vitamin A and D, please. And we have to treat renal failure quickly. Still on follow-up and possible preventive measures, the individual already diagnosed with hypercalcemia should be examined for multiple endocrine neoplasia, particularly multiple endocrine neoplasia 1 and 2A. And we have to continue checking the calcium and albumin level. We have to treat hyperparathyroidism promptly, hydration properly, and of course, good protein diet for chronically ill patients. Know why? Hypoalbuminemia will lead to more calcium to be free, and that is our problem. Okay, and with that, I'm going to conclude all presentations as per hypercalcemia. Please review parts 1, 2, 3, and 4. I'm wishing all affected people quick relief and speedy recovery. That is QRASR. Thanks for listening. Remember to share and subscribe. I appreciate it.